So this is again the whole case. This is one case of
In one case of DM hypertension, IHP started for CABG 1999 with 2008 he underwent PCI. Then 2014 he became the end stage of renal disease status post renal transplant in 2014.
So as I was telling you, when you have renal transplants versus liver transplants, okay, and the patient comes into the intensive care unit with some kind of problem, the first thing you'll always suspect is sepsis. First thing, because of the fact that they are chronically immunosuppressed. What is the difference between immunosuppressed and immunocompromised? Immunocompromised is because he has a condition that causes immunocompromised status like HIV, like etc. Whereas immunosuppressed is when they have pharmacological suppression, like for example, tacrolimus, MMF, and things just like that. The difference between the transplants of liver and renal is the fact that liver is less has less graft rejection as compared to kidneys. So in kidneys, whatever happens, even if it is gross sepsis, you may not want to cut off the tacrolimus at any given moment. You need to give some steroid or something. You need to give. You cannot stop the immunosuppression in kidney because they go into graft rejection very quickly. And that is the reason that if you have a patient that is coming with query sepsis, you have to hit very hard. You can't treat them as community-acquired sepsis. You have to treat them with very high generation drugs, because what can occur is that in the background immunosuppression, pharmacological, they may not respond well to the existing line of therapy. That's why you require very high-profile medicines in the first place. Right? Now, what did this patient present with? You are seeing he present with drowsiness because of urosepsis. He was treated, went to the wards, and then came back with a hypercalcemia. Now, at this stage, it's very important for you to show what is the calcium. Now, the calcium here in our reports, what is the calcium showing here? So, the calcium here is showing as, the ionic calcium is showing as 7.32. This is what it is showing. But what, as a doctor in the round, you must understand is there are various units. First of all, you always should do ionic calcium. You cannot do normal calcium. Okay, ionic calcium is the active biological component of calcium that you have to monitor. And all the problems that would occur with calcium would be based on ionic calcium, not normal calcium. Now look, ionic calcium is showing as 7.32 milligram per dl. 7.32 milligram per dl. Now remember this is very different from the units otherwise. So if you look at the units in a blood gas, which is done simultaneously, it is showing calcium of 1.59 here. 1.59. Here the normal value is 1.15 to 1.33. This same ionized calcium. The units here, the units are millimoles per liter, whereas here the unit is milligram per dl. Milligram per dl. On an average, what you must understand is whenever there is hypercalcemia, it is called severe. Then it is usually double this amount. So here I would call it to be severe if it is somewhere around more than 10 milligram per dl. Whereas here I could call it as if it is somewhere between above 3 millimoles per liter. So ionic calcium, same ionic calcium in two different units and two different numbers. You must remember this, okay? And this is very different from ionic calcium that comes in. Similarly, even for total calcium, milligram per dl and millimole per liter is different. Okay, so milligram per dl, there will be 9 to 11 such patients. What do you think can occur in such patients? So why for a muscle cramp patient would come to ICU, no? So if a patient has got gross calcium deficit, why would the patient come to the ICU? What would be the presentation to the ICU?
Lethargy.
Yeah, so everything will slow down. Calcium in the body, if it is there too much, everything will slow down. Okay, so he can get drowsy, he can get disoriented. Okay, then what else can occur with the muscles? There can be depressed reflexes. When it comes to muscles, there is depressed reflexes. Depressed reflexes when it comes to muscles. Correct? Then what else can occur in such patients? In the ECG, do you see any changes here?
Interval.
Sorry?
Shortening of the interval.
Shortening of the what?
QT interval and PR.
So you are telling 3-4 things together. Show me the ECG, sister. Get out the ECG. Let's take the ECG out. ECG nikalo, sister. ECG from the file, please. So, what are the various intervals you know? First of all, you are talking so many intervals together. You are supposed to tell me the interval first. Which are the various intervals you know?
PR.
So let's put it this way: P, Q, R, S, T. Okay. So which are the various intervals you know here? Where is the latest one that when you was admitted here, shifted here? When you shifted here, where is the ECG, sister? I want the ECG for 4th. Take it from the file and show me from the 4th. So 30. Take it उसमें से निकालो. Give me the 4th ECG. So which are the? So what did we say as the symptoms were? So The symptoms that we talked about was what? Was nerve related issues, confusion, little bit drowsiness, muscle weakness. ECG per se will not change too much. So you may have an LBBP pattern, you may have bradycardia, but you will not have huge ECG changes. It's not classical. Okay. However, they can have a short QT. Short QT interval. A short QT interval would have an Osborne wave. These are two things that you might see on an ECG per se. So, but the investigations that you would like to send baseline in these cases, that for diagnostic purposes, one is always calcium, magnesium, and phosphorus. Okay. Then the other thing you want to send is serum parathyroid levels. Serum parathyroid levels. Third, you want to send is vitamin D levels. So you want to send 125 dihydroxy vitamin D3 as well as 25 hydroxy vitamin D3. Now, why is that so? Not really. So how does this work? So in your liver, there is something called 1-alpha hydroxylase enzyme. Okay. So when you eat a vitamin D or you take sun, both of these, they convert to 25 hydroxylase, and this then converts to 125 hydroxylase with the help of hydroxylase, 1-alpha hydroxylase. 25 hydroxy is converted to 125 hydroxy. Correct. Now this can also occur in the presence of granulomatous diseases. It can occur because of TB, it can occur because of lymphoma, it can occur fungal infection. So granulomatous disease like sarcoidosis, TB, fungal infections, lymphomas, this can actually cause this without this. So in this case, what will happen? The 125 will be high, when vitamin D3 will be low, will be normal, because this will go higher. That's why when you are doing the investigation for this, you may want to do 125 as well as 25 hydroxy vitamin D3. Both you may need to do. Clear on this? And the last investigation would be a scan. And the scan, just hold on, I'll show you. So let's see the intervals that you have normally. So normally, if you have, what is PR interval?
From the P to the starting of the Q.
Pre, beginning, P, end. So the P starts from start to the beginning of R. This is PR interval. The PR segment is from the end of P. This is the segment, PR segment. This is PR segment. This is the PR interval. This is QRS interval. QRS interval. Okay, what is QT interval?
From Q to starting of T.
From Q, from here.
From here, sir. Q.
You have to enable it here, or here. Where are you talking about? You're not telling me anything right.
From here, sir.
Till where?
From the starting of T.
No. So again here, it starts from Q, okay, and goes to the end of T. Okay, so QT interval. So you have QT interval here. This is important for you to know, because QT interval could be, there may be a U wave here. There may be U wave here. Okay, so it starts from Q and ends at T. Okay, ends at T. Clear on this? It ends at T over here. Clear? Now when I'm doing this QT interval, what is important for me is, say for example, this is Q is coming like this, and it is coming down and there is a U wave. Which will you take? I will take this point. But if I have Q like this and coming like this and like this, sometimes it does happen like this. So then what I will take? I will take this end. You understand? If it is somewhere, that's if it's a discernible P. Now if it is this way and becoming like this and then becoming up, slightly up, then I will take the direct angle down here. You understand? If it is not discernible. So you have QT, that's how you take the T. So you have to take the angle. Okay, that's QT. So QT normal for adults 440, के ऊपर अगर गया 460 in males and 440 in females is considered to be abnormal. So in these cases, you can have a very short QT interval, The short QT interval will signify that there is hypocalcemia. But however, bradycardia and asystole and all these very malignant rhythms are not seen with hypercalcemia. All these, they may have blocks, they may have left bundle branch block, they may have sometime an Osborne wave, which basically means a wave that comes like this. So they may have an Osborne wave at times. Okay, but however, all these rhythm abnormalities do not cause major problems to these patients when they are in the ICU. Okay, for hypercalcemia. So how do you evaluate this hypercalcemia? So you have a patient with high calcium. So how do you evaluate this patient? What do you send? So first of all, if there is high calcium, what do you send? You will send the rest. You will send magnesium, you will send phosphorus, you will send potassium. So these three things you will send, because we normally say that once there is one single electrolyte abnormality, there is bound to be other electrolyte abnormalities. Right? So that is why you send the rest of these things, and they may give clues to the diagnostic capabilities of why this hypercalcemia has gone up. Then what is the next thing for etiology? What would you do? Sorry? PTH. So serum PTH. You will send a serum PTH levels. Okay. Now if the serum PTH is low, serum calcium is high, and serum PTH is low, what does it say?
Second.
Let's take an example of serum calcium being high and serum PTH is high. What does it say?
It's primary.
That means there is the parathyroids are 4 glands which are there in the they are classified as superior, they are classified as inferior glands. Okay, parathyroid glands. Now these glands, if they become hyperplastic or adenomatous, that is bigger, this is called as primary hyperparathyroidism, where what happens is they secrete a large amount of PTH. And because it secretes a large amount of PTH causes calcium to be absorbed from the bone, calcium to be absorbed from the gut, and causing hypercalcemia. Okay, so you get high calcium and high parathyroid hormones. In normally parathyroid, we will call it as primary hyperparathyroidism. Correct on this? Clear on this? When it is the other way around, okay, then it is called as secondary hyperparathyroidism, which is basically completely different. It is not related to the parathyroid. It is everything else. It is everything else. It is not related to parathyroid. It is everything else which is causing this. And the last one you say is tertiary hyperparathyroidism, where autonomously parathyroid gets released.